Hello and welcome. My name is Maddie Curry. I am an enrolled descendant of the Blackfeet Nation and a public health program manager at the National Council of Urban Indian Health, also known as NCUI. Today's session will start with an overview of American Indian and Alaska Native maternal mortality, and then we'll move into introducing Maternal Mortality Review Committees, or MMRCs, as a mechanism for reducing AI/AN maternal mortality. You'll also see a QR code for a survey to provide feedback on today's event towards the end of our slides. So please, again, provide that feedback and you could have an opportunity to get some NCUI swag. Next slide. Today's event will be recorded and shared on NCUI's YouTube channel. We hope that you will turn on your video to help us better engage with you, and that you please unmute yourself when you're, please mute yourself, when you are not speaking. We also ask that you please enter your name, organization, and tribal affiliations into the Zoom chat. Thanks. All right, so to provide a little background on us, the National Council of Urban Indian Health, also known as NCUI, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUI is the only national representative of the 41 Title V Urban Indian Organizations, or UIOs, under the Indian Health Service and the Indian Health and Care Improvement Act. NCUI strives to improve the health of over 70% of the American Indian and Alaska Native population that lives in urban areas, supported by quality health care centers. We also want to acknowledge that NCUI is proud to partner with the U.S. Centers for Disease Control and Prevention through Cooperative Agreement OT 18-1802, strengthening public health systems through national partnerships to improve and protect the nation's health. The CDC is an agency within the Department of the Health and Human Services, and the contents of this program do not necessarily represent the policies of the CDC or HHS and should not be considered an endorsement by the federal government. Next slide. We also want to take a moment to recognize that addressing maternal mortality, and more specifically American Indian and Alaska Native deaths, is an incredibly sensitive topic, and it might affect some participants today more than others. So if you find yourself impacted by today's discussion, please connect with your support networks or reach out to NCUI and we can provide you with healing resources. Thanks. All right, so now I would like to introduce today's presenters. First, we have Michaela Sieber, who's our guest speaker for today, who has graciously offered her time to discuss her experiences working with MMRCs and AI/AN maternal deaths. She's the Chief Executive Officer of the South Dakota Urban Indian Health, a NCUI board member, and serves as a tribal representative on South Dakota's Maternal Mortality Review Committee. Michaela grew up in Sisseton, South Dakota, and is a tribal member of the Sisseton Wahpeton Oyate. Michaela received her undergraduate degree from South Dakota State University in 2013 and her graduate degree in public health from the University of South Dakota in 2016. She has experience working in public health, community-based participatory research, research ethics in tribal communities, grant management, and program development. So thank you, Michaela, for us today. We also have myself and my two colleagues from NCUI, Nala Holland and Alexandra Payan, who will be sharing we will be sharing our knowledge as subject matter experts, respectively. All right, so in order to start off this discussion in a good way and to honor the ones we've lost and the ones that we are aiming to protect with this work, Michaela has offered to provide us with some grounding words to open up our discussion. So Michaela, the floor is yours.
Thank you, Maddie. Petu Washte Mitakiapi, Michaela Sieber, Amakiapie, Da Makota, Anishinaabe, Ka Washichu, Sisseton, Hematahaye, Sisetuan, Wapituan, Oyate, Ed Omawapiye, Sioux Falls, Ed Wati. Hi, everyone. Like Maddie said, my name is Michaela Sieber. I am Dakota, Anishinaabe, and East Tennessee Hillbilly from Sisseton, Wahpeton, Oyate. I live right now in Sioux Falls, South Dakota. I'm so honored and happy to be here and sharing this space with everyone. I did want to just spend a few minutes giving an opportunity for all of us to prepare ourselves for the discussion we're about to have today. These are hard topics to discuss, and I want to make sure we're all taking care of ourselves throughout this work And so normally before I have meetings like this, I always take a moment to smudge and think about what my goal is for the meeting or the discussion. And so I did want to give everyone just like a minute for everyone to do that today. And so just think about the important work that we're talking about, and remember that behind each data point that we're discussing today, there are real people and real families and communities grieving the losses of these lives. But between all the sadness that you'll probably be feeling as we talk about this, and that I feel during all this work, there's hope in this. These discussions are really important for that hope, and initiatives like those you'll hear about today are helping us to improve that. So Maddie, if we could just give like a minute for everyone to just take a moment for themselves. If you smudge, practice, you can go ahead and take that minute. That's what I'm going to be doing, but just prepare yourself for everything today. So, Pramia.
Thank you so much, Michaela, for ensuring that we start off today's session with good medicine. I hope that everyone was able to take a moment for themselves. So we're going to move into some instructions for how to participate in today's discussion. We hope to have a really robust discussion with everyone who's here, so everyone can share their knowledge in this work. So throughout our time together, we'll also have opportunities for you to participate in discussions and polls via the use of the Poll Everywhere platform. You can participate by using an internet browser or on any of your devices by texting your responses. So you'll see the instructions here. You can visit pollev.com/wiredsend334 to join through your browser, or you can text wiredsend334 all caps to 22333. Also, the probably easiest way is to just scan this QR code to join the poll. So there'll also be instructions in the Zoom chat too. So to begin and to also test out this the Poll Everywhere platform, Lamar, if you can move into our icebreaker. So using 1 or 2 words for this icebreaker, and to start us off, please describe the roles that mothers, birthing people, and matriarchs play in your community. This will be a word cloud, hopefully, so you can type in as many responses as you'd like. And if you need assistance with any instructions, please type in the chat or unmute yourself. And then if you'd also like to expand on your answers, please feel free to unmute yourself as well. Backbone, foundation, wisdom, protectors, teachers, providers. I'm loving this. We'll leave this up for about 30, 45 more seconds. Support, lots of teachers, wisdom, support, kindness, mentors, comforters, forgiveness. Pillars, blankets, yes. Nice little heart there too. Superheroes, yes, absolutely. History. Wow, this is really great to see. I'm really glad this is working out because we have a couple more opportunities for word clouds throughout this time with us. So this is amazing. Great, awesome. So I think maybe we'll move on from that, and then as we go through, we'll have some more opportunities for word clouds. So thank you so much for that. That was a really great way to start us off. So now Nala Holland, our data and research expert with this project, will provide us with an overview of AIA and maternal mortality. So Nala, you have the floor.
Thank you, Maddie. So I will be providing context on American Indian Alaska Native maternal mortality for you all today. So what is maternal mortality? The definition of maternal mortality can be slightly confusing as different organizations use different terms and have different time ranges. Maternal mortality review committees, though, look at cases where an individual dies during pregnancy or up to 1 year after birth from any cause related to or aggravated by the pregnancy. If you look at World Health Organization data and National Vital Statistics System data, their time range for what is considered maternal mortality is during pregnancy up to 42 days after birth. These ranges are important to note because data will be inaccurate if you're using World Health Organization maternal mortality ratios to compare against the state maternal mortality review committees maternal mortality ratio. Also, these time ranges are important because according to a 2017-2019 review of 36 state maternal mortality review committees, 29.4% of all American Indian Alaskan Native cases the MMRC received were pregnancy-related deaths that occurred after 42 days and 42-day mark, so between 43 to 365 days. And this percentage is consistent with all other cases the Maternal Mortality Review Committee reviewed, regardless of race and ethnicity. Deaths occurring after that 42-day mark comprised just under a third of all maternal mortality deaths. And these cutoffs are also of relevance again because we see that federally Medicaid is only mandated to cover pregnant people until 60 days postpartum. 29 states have extended their coverage to cover up to 1 year postpartum, but this is especially concerning for those people who are pregnant in those states that don't have that coverage, as a recent study showed that 60.2% of identified Indigenous patients in the US were using Medicaid as their primary insurance. Next slide, please. So let's get clear on the terms used around this topic though. So maternal mortality will always be defined as deaths that occurred during or 42 days after pregnancy, and that death is related in some way to the pregnancy. So that is the term that World Health Organization used and National Vital Statistics System uses. And then we have pregnancy-related and pregnancy-associated deaths. And that is technically what maternal mortality review committees will look into. So pregnancy-related death is a death during or up to 1 year after pregnancy, with the cause of death being somehow related to the pregnancy. For example, hemorrhages or suicide related to postpartum depression. And then we have pregnancy-associated deaths having that same 1 year postpartum timeframe, but the death is not necessarily related to the pregnancy. And again, these terms kind of get confused, especially as when the media reports on this issue, they often won't be using the terms in the way they're supposed to. So always check the sources to know if they're using that 42-day cutoff or if they're using that 1 year. Next slide, please. Now let's put in perspective American Indian, Alaska Native pregnancy-related deaths compared to other racial ethnic groups in the United States. This is pregnancy-related deaths from the CDC Pregnancy Mortality Surveillance System. So these are up during pregnancy or up to 1 year postpartum mortalities. While the US rate in general for maternal mortality / pregnancy-related deaths is high compared to other developed countries, there are clear disparities by race and ethnicity, with the most affected populations being individuals who are Black or American Indian and Alaska Native individuals. Variability in the risk of death by race and ethnicity may be due to factors like access to care, quality of the care received, prevalence of chronic diseases in that community, structural racism, and implicit biases those individuals face during the pregnancy. These ratios are for all 36 states with an MMRC during this time frame and for all ages, but just for your knowledge, that data can vary by age and by state, usually with the ratios increasing as ages increase. So let's look at the graph though and what it's actually telling us. So for every 100,000 live documented non-Hispanic American Indian Alaska Native births in 2016 to 2018, 26.5 would result as pregnancy-related mortalities. This is double the rate for non-Hispanic white births in that same period. Additionally, this data only includes cases that were marked as American Indian Alaska Native, and racial misclassification is another factor that may be affecting the results. Racial misclassification of American Indian Alaska Native death certificates is a documented problem. More specifically, the race and ethnicity and/or tribal affiliation of an individual is often left up to be determined by the person completing the death certificate. So that could be a funeral director or a medical examiner. And they do not always ask people close to the individual for confirmation of the demographic information, and thus leads to many American Indian Alaska Native people being misclassified as non-American Indian Alaska Native. But MMRCs do look at other information regarding an individual besides death records, but some maternal mortality review committees only allow for single race to be selected for an individual. As we see in this graph, if an individual was identified as Hispanic in combination with American Indian Alaska Native, they were excluded from the American Indian Alaska Native group. Next slide, please. This data set is from the CDC ERASE Maternal Mortality Program, and it tries to adjust for that racial misclassification of American Indian Alaska Native pregnancy-related deaths. And this graph data set is showing causes of pregnancy-related death for American Indian Alaska Native population. And they tried to adjust for racial misclassification by allowing multiple race identified American Indian Alaska Native individuals into the American Indian Alaska Native data set. So for example, if somebody identified as Hispanic and American Indian Alaska Native, unlike that previous graph we just saw on the other slide, in this data set, they were included in the AIAN category. But you can still see that the reported case numbers are still low for this data set on this slide. And however, when racial misclassification was adjusted for, mortality rates did increase for American Indian Alaska Natives in this data set and in other data sets and other studies outside of pregnancy-related mortality rate. But let's focus on what this table can tell us from the cases it does include. So this is underlying causes of death for all American Indian Alaska Native pregnancy-related mortalities for 36 maternal mortality review committees in the years 2017 to 2019. And you can see that the highest condition with 31.3% of all cases were maternal health conditions. And that's inclusive of suicides, poisonings, overdoses, substance use disorder. And coming in second with almost 1 in 5 cases being hemorrhages. And this isn't specific to hemorrhages during delivery, but also is inclusive of postpartum hemorrhages. And we also have amniotic fluid embolisms, infection, and pre-existing conditions like cardiac and coronary conditions, autoimmune diseases, and then conditions unique to pregnancy and injury. Next slide, please. So on the bright side of all of this data that is not the most uplifting, pregnancy-related deaths are largely preventable. So what we mean by when we say a preventable death is that a death is considered preventable if the committee determines that there was at least some chance of the death being averted by one or more reasonable changes to patient, community, provider, facility, and/or system factors. So, to give you a number, of all maternal mortality review cases in 2017 to 2019, 84.2% were preventable. And then when we specifically looked at American Indian Alaska Native cases, we saw that 93.3% were preventable. And what we saw in that last slide demonstrated for the available data of American Indian Alaska Native pregnancy-related deaths, roughly half of all those pregnancy-related deaths for American Indian Alaska Natives is from hemorrhages or mental health conditions. And this is really important to note because those two conditions just on their own are largely considered to be preventable. So for hemorrhages, is considered preventable by active management of that third stage of labor to prevent that postpartum hemorrhage, as well as recognition and response to hemorrhages by medical professionals and the patient themselves. And for mental health conditions, by increasing social support, community engagement, behavioral and mental health treatment and access, as well as increased insurance coverage for those necessary services. So maternal mortality review committees are a valuable resource in understanding pregnancy-related deaths and developing strategies to combat this issue. And they help communities prioritize necessary interventions to combat maternal mortality, as we see in the AIAN data set with the focus. The maternal mortality review committees are able to identify hemorrhages and mental health conditions as a necessary focus for Indian country. And next slide, please. So I will open it up for questions on what we just discussed, if anybody has them. And feel free to unmute yourself or to type any questions in the chat.
Like there's sorry, a couple of questions in the chat for you, Nala. Are deaths due to domestic violence included? Do you know? Yeah, so if the domestic violence is somehow, if the Maternal Mortality Review Committee determines that the domestic violence incidence was related to the pregnancy or that individual being pregnant, it will be considered a pregnancy-related death. And a non-pregnancy related death could be like a car accident, something, and it wasn't the individual's fault and it had nothing to do with the pregnancy. Right, that makes sense. And then there was a comment from Lyle that they said it would help me to know what conditions are not considered preventable. But that might just be a general comment. Yeah. So for the majority, most of them are considered preventable. The ones that were not, for the American Indian Alaska Native data set specifically, there was one where it was undetermined if it was preventable, but they didn't specify why it was undetermined. And they didn't specify conditions that were considered to be not preventable.
I don't know if anybody else on the team has any more insight into that though.
Yeah, they followed up medical conditions like amniotic embolus, those sorts of things, that really can't be prevented, but are an unfortunate cause of a maternal death. Okay, for the sake of time, thank you so much, Nala. I'd love to move on. That was extremely informative. Thank you for sharing your knowledge with us. So we're going to move on to kind of an activity right now to set some more context. So again, we're going to continue on with a poll. So if you still have that pulled up on your phone in your browser, this question should automatically pop up. But if you would like, yes, Lamar can pull up the QR code if you need it again. But for now, the poll that we're going to ask, we would like you to rate maternal mortality as a concern in your community on a scale of 1 to 5, with 1 being no concern and 5 being maximum concern. Again, if you have any questions, please, or if you would like to, expand on your rating, please feel free to type in the chat or unmute yourself. And then Rebecca, I noticed your question in the chat, and we'll make sure to follow up with you on that after this event concludes. Thank you. Okay, so it looks like most everyone is, oh yes, and then some, Lamar, if you could just pull up the QR code again, thank you. It looks like someone's looking for it in the chat. So if you can just take a picture and it should be able to pop up in your browser. Okay, thanks. Yeah, so it looks like things are, pretty weighed pretty evenly towards moderate to maximum concern, which is, pretty not surprising considering the statistics that we just went over. Okay, great. Yeah, that's pretty standard. Okay, so we'll save those and move on to the next slide, Lamar. Thanks. So now that we understand AI and maternal mortality from a research perspective, we also wanted to share a video that was developed by the Hear Her campaign at the CDC. This campaign is intended to amplify the voices of American Indian women who have experienced complications during or after their pregnancies. So in this video, we'll hear from Sarah and her experience with postpartum depression and how she was able to get the care she needed. Again, this video might be distressing to some viewers, so we encourage you to engage with your support networks if you need. Lamar, you can go ahead and play the video. Thanks.
My name is Sarah Six-Killer Dumas, and I'm a member of the Cherokee Nation tribe, and I live in Tulsa, Oklahoma. I have always wanted to be a mom. My first pregnancy was easy breezy. My second pregnancy was a little harder on my body. My delivery was ideal. I thought, I've got this. I've done this before. He just wasn't getting enough milk. So I had a friend that had just had a baby a few months prior, and she said, you have to call a lactation consultant. She was so helpful and so kind, and I just instantly felt comfortable with her. And I didn't think I would, some stranger coming in my home, telling me how to feed my baby when I felt like I should know how to do this. I should be able to do this. And that was the mentality I think that set me up to kind of go down that dark hole of postpartum depression. I would just feel like maybe my baby would be better off with another mom. Why can't I do this? This is what my body was made to do. So what's wrong with me? I must just not be good enough. It just felt like a really heavy weight on me. Everything was on me. And that was it was unbearable at times. When I first started to have the negative thoughts and feelings after giving birth, I think it was the polar opposite of not connecting with my little one or not feeling like I was bonding. It was such an over the moon kind of such a bond and such an attachment that I felt like it was solely my duty to provide everything he needed. And so you just lose sight of yourself and what you need. I just wish that I had told someone. I almost lost myself in that. I can only describe it as the longer that I waited to talk to someone about it, the deeper I went into the hole. And I was afraid that I wasn't going to come back from that. And I just didn't, at that point, I didn't know who to tell, because I felt like there was so much that had piled up over time that it just wouldn't be safe for me to let that out, because it seemed crazy. And why hadn't I told someone sooner? Once you let it out and once you tell someone, that person that you trust can help you find some help. So Montika helped me to know that it was okay, that I wasn't okay. In her genuine desire to help, saw me and heard me and knew you need a little bit more than lactation help. And so I feel like her ability to hear me and genuinely interested in how I was doing and helping me formulate a plan of care was instrumental in me seeking out counseling and letting my family know that I wasn't okay, that I was putting on a facade. Being a mom is so hard, but it gets easier. It's almost impossible to ask for help and not feel guilty, because you're supposed to be able to do it all. But that's just not true. That's just what we tell ourselves. I've always been the caregiver for everyone. I deserve the care that I deserve, and I deserve to be heard, and I deserve for my health and my mental well-being to matter, because that matters to everyone in my household, not just me. But I can't take care of everyone else if I'm not being taken care of. Sometimes we just need help, and we need to call someone for help. If you're having a baby, or if you just had a baby, I really would just encourage you to find someone that you trust and just really be honest with them about the thoughts you're having, the feelings you're having.
Okay, great. So if you have any questions about that campaign, the Hear Her campaign, please feel free to reach out to me or us at NICUI, and we can get you connected with the folks at CDC running this campaign. Okay, so let's move on. Next slide. So now that we have all of this context, we'll take some time just to have a quick open discussion on what we just covered. More specifically, why do you think that Native American, American Indian and Alaska Native maternal mortality is happening? And more specifically, why might these maternal deaths be occurring at a greater rate for American Indian and Alaska Natives? Please, take some time. We'll spend about 2 minutes here, and then you can write your answers in the chat, or feel free to unmute yourself. This would be a great opportunity for discussion.
So I think that it's kind of a multifactorial situation. Depending on the cause of maternal death, I think a lot of things related to postpartum depression and stuff have to do with the amount of trauma and stress that mothers are already in the community, contributing to that. And then, it's all kind of it all kind of runs together, if that makes sense.
Rebecca, yeah.
Greetings, everyone. My name is Rebecca Riley. I live here in Albuquerque, New Mexico. I'm an enrolled member of the Pueblo of Acoma that's also located in New Mexico, about 60 miles outside of Albuquerque. And I feel like a major component has been a loss of our cultural and traditional values with the influence of Westernized teachings around what it means to be a Native person birthing in the United States. And I feel like for the most part, as Native Indigenous people, we've always had this sense of community and relationships to each other, and that we were not ever, no one was ever birthing children on their own. There was always this sense of relationship and community around, when a baby was born within the tribe. And so that loss and sense of, that communal support, along with reasons why perhaps things happen the way that they happened, we always had a response to that. And we always had a response that made the most sense for that particular time and person. And so now we have this call to action around culturally relevant, culturally sensitive care. We have to put in place various interventions that include trauma-informed care. But really, it's this sense of returning back to how we understand and respond to the care of a person that is giving birth and the birthing process that we are needing and deserve. So I feel like that interconnects with all these other challenges that as Native people, we are trying to solve or learn or relearn how to do again. And so I just feel like a lot of the things that we are wanting are kind of returning back to that, and what it looks like, in this day and age, what it looks like for future generations with all the information, knowledge, and research that we have, both our academic knowledge, but also our experiential knowledge, meaning, our understanding of what culture looks like now. And so I feel like it's a really big question, but I just wanted to offer that up. Thank you.
Thank you so much, Rebecca. Absolutely. It's a very large question. Michaela, we'll hear from you, and then we'll move on, unfortunately, just for the sake of time.
Yeah, I'll just share quickly. I think there's a lot of systemic things that are contributing to this. So just policies with our Western health systems and providers, and how we're teaching our future physicians and nurses, and just how to treat our Native relatives. So I think there's a lot of systemic things that are a large contributor to this as well.
Yeah, absolutely. Systemic barriers are definitely a barrier. Absolutely. There's also a great amount of comments in the chat for this. Thank you all so much for your participation. I wish we had, 2 hours to read all of these comments, but take a look and, read yourself. And, a lot of these, I'm seeing a lot of, really recurring themes. So yeah, we will move on. So thank you all again for that wonderful, robust conversation. So, we just covered all of the risk factors, most of them associated with increasing AI/AN maternal mortality rates. So while there are these, risk factors, there are also protective factors that exist in every Native community to promote strength and healing. Protective factors are conditions or variables that are capable of directly affecting a specific population and increasing the likelihood of positive health outcomes. So some examples of AI/AN protective factors can include connectedness to individuals, family, and your community, having cultural identification, spirituality, positive self-image, self-efficacy, and identifying these protective factors at the individual, relationship, and community level, and recognizing ways to also leverage these factors are foundational to promoting AI/AN maternal health. Next slide. Okay, so for this next activity, that was a very brief overview of protective factors, but we are hoping to create a word cloud of protective factors that will continue to inform our work as we move forward with this project. So again, using the Poll Everywhere feature, please enter any protective factor you can think of in your community that might contribute to maternal health promotion. You can also respond more than once. So please, if you have multiple factors, enter all of them, and you can enter them separately. And if you'd like to expand on your entry, please feel free to unmute yourself or type in the chat. And we'll spend about 30 seconds to a minute here. Cultural connections, matriarchs, support, family. Yeah, that's a big protective factor. Absolutely. Aunties. Love my aunties. Breastfeeding. Having cures. Language. Yes, language. Ceremony, elders. Big emphasis on family. Absolutely. I saw someone wrote in the chat, rituals, counseling, support, indigenous community, foods. Yes, absolutely. Oh, someone also noted in the chat, ceremony, sweat lodges, doulas from the community. Can't keep up with all of these. This is awesome. Themselves, yes. Great. Thank you so much. This was great. Love to see all of these protective factors that you are all coming up with. It's great to think about the more positive things throughout this. Okay, so we'll move on from this word cloud. This will definitely inform us for later. So moving right along, thank you everyone for your participation in that activity. We're now going to transition from learning about AI/AN to maternal mortality to understanding what maternal mortality review committees are and also their role in preventing AI/AN maternal mortality. So now I'm going to give the floor over to my colleague, Alexandra. She is a Federal Relations Manager at NCUE, and she will tell us about the purpose, history, and legislation behind MMRCs. So Alexandra, take it away.
Thank you, Maddie. As Maddie said, I'm going to discuss the purpose first. So Maternal Mortality Review Committees, or MMRCs as we call them, are multidisciplinary committees that convene at the state or local level to comprehensively review deaths that occurred during or within a year of pregnancy, also known as pregnancy-associated deaths. So they include representatives from public health, OBGYNs, maternal fetal medicine nurses, midwives, forensic pathologists, mental and behavioral health providers, as well as patient advocacy groups and community-based organizations. The CDC works with MMRCs to improve review processes that inform recommendations for preventing future deaths. And funding through the CDC or funding for MMRCs comes through the CDC. The CDC has made 39 awards supporting 39 states and 1 US territory for enhancing reviews and surveillance to eliminate maternal mortality. This is referred to as ERASE MM. This funding directly supports agencies and organizations that coordinate and manage maternal mortality review committees to identify, review, and characterize pregnancy-related deaths and identify prevention opportunities. This work will facilitate an understanding of the drivers of maternal mortality, as well as the complications of pregnancy to help them better understand the associated disparities. This work also helps to determine what interventions at patient, provider, facilities, as well as systems and community levels will have the most effect. And also it works to inform the implementation of initiatives in the right places for families and communities who need them most. Next slide. The need to examine maternal deaths in greater detail to develop strategies for prevention has been recognized for over a century. In the 20th century, some states established MMRCs to investigate deaths related to pregnancies when they were the highest on records. And in fact, beginning in the 1930s, maternal mortality review committees formed at the state and local levels to address this need. Starting in the 1980s, many communities became inactive as there was a decline in maternal deaths for many decades. However, in 2016, there was a resurgence of MMRCs due to increased awareness of disparity rates among maternal mortality by race. Next slide. There has been a lot of legislation for MMRC, and NCUI has endorsed several areas related to maternal and infant health as well. Not all proposed bills and related legislation has become law. However, there's several bills and areas that NCUI is supporting and that I just want to highlight specifically as they have been cornerstones in the MMRC process. So in 2018, the Preventing Maternal Deaths Act was created into law, and this amends the Public Health Service Act, reauthorized through FY 2023, and revised certain CDC programs that support state and local surveillance of maternal mortality. On December 21st, 2018, this act was officially signed into law, and it established a federal infrastructure to collect data on every maternal death in every state to carefully review each of the contributing factors leading up to the death and all the data that it established strategies and best practices for prevention. However, questions remain, and the topic is bound to arise during upcoming elections, especially given that this is set to sunset in FY 2023, so this year. Additionally, this Preventing Maternal Deaths Act allocated federal funds and directed the U.S. Department of Health and Human Services to establish a program that directs funds to 5 crucial tasks. And these tasks include reviewing all maternal deaths, establishing and sustaining MMRCs in every state, developing for every state a plan for ongoing healthcare, provider education to improve the quality of maternal care, distributing maternal mortality review information applications into every state, and providing public disclosure of information found for these review committees in the form of state reports. So the passage of this act occurred due to increasing rate of maternal deaths and their higher preventability, as Nala mentioned, as well as a shortage of reliable data. I'm also going to go quickly through these next few areas of legislation, but there was the Data to Save Moms Act, and NCUI actually endorsed this act. This specifically included $2 million for Indian Health Service to study maternal mortality and severe maternal morbidity. There was also the Moms Act of 2021, which discussed modernizing obstetrics medicine standards. And this legislation was intended to expand the Alliance for Innovation and Maternal Health programs. Additionally, there was the Maternal Health Quality Improvement Act, which appropriated $9 million for grants to identify and develop best practices to improve maternal health quality and mortality through maternal mortality review committees. And then the Mamas Act, and this appropriated $5 million to have the HHS director issue best practices to MMRCs, especially on how to identify and review maternal mortality cases, taking into account many data sources. So each piece of legislation, while not all have become law, are all steps in the right direction to improving maternal mortality health outcomes. And NCUI continues to support legislation aimed at improving maternal health outcomes and has been involved in providing input. Additionally, to the Advisory Committee on Infant and Maternal Mortality, NCUI actually helped provide recommendations in their report to the HHS Secretary. And NCUI is also engaged with leadership on the Hear Her campaign. And we are really encouraged and seeking to strengthen our relationship with the Hear Her campaign in the upcoming year. And with that, I will turn it over to Maddie.
Great, thank you so much, Alexandra. That was incredibly informative. So now we're going to do a little deeper of a dive into how an MMRC actually functions. So MMRCs are considered the gold standard in identifying and reviewing pregnancy-associated and pregnancy-related deaths by utilizing a multidisciplinary team for a comprehensive process in maternal death case reviews. As we stated before, they're critical tools about facilitating and understanding the drivers of maternal mortality and pregnancy complications. So you'll see through this logic model, this was created by the ERASE team at the CDC, along with the intended outcomes of the ERASE program over the short and long-term periods. So ideally, a fully successful MMRC will be functional, sustainable, have robust and accurate data, establish health surveillance and data analysis methods to build strong evidence bases, make recommendations, and then also through these successful outputs, the long-term goals of eliminating preventable maternal deaths and reducing maternal morbidity can be achieved. Next slide. MMRCs are extremely important because they create an opportunity to build a complete understanding of the mother's story and what led up to their death. By collecting as many information sources as possible, the goal is to reduce any misunderstandings, misclassifications, or discrepancies that might occur in a more traditional and singular autopsy report, for example. So to tell these stories, MMRCs utilize extensive information sources, which can be listed here, as you can see. Namely, key informants, including family and friends, has been proven to be essential and crucial for building out the full narrative of the maternal death. Next slide. So who sits on an MMRC? Well, historically, they were primarily comprised of medical professionals. MMRCs have since expanded to include a vast array of professionals and partners who engage and serve people during pregnancy and the postpartum period. So shifting to these multidisciplinary committees is also essential for AIA and maternal death review. And here is a long list of professionals and informants that can be represented on an MMRC. Next slide. All right, so how does an MMRC actually work? So they work in a very cyclic pattern by first identifying a maternal death case, then selecting that case for review, abstracting all relevant information, utilizing all of the information resources I just went over, developing the narrative of what caused the death and the relevant circumstances that also led up to the death, along with also provided recommendations that would have prevented the death. So then they'll review this narrative, document, analyze the recommendations, and then finally implement and evaluate to ensure that those recommendations are effective. There are also 6 key decisions that MMRCs must make for each death review, but the top 4 decisions are: was the death preventable? What were the contributing factors to the death? What are the recommendations and actions that address those contributing factors? And what is the anticipated impact of those actions if implemented? Next slide. So here we have an example of the recommendations that were created by the Washington State Department of Health Maternal Mortality Review Panel out of the findings of a 2019 report that reported on maternal deaths in Washington State from 2014 to 2016. So while all of these recommendations are not specific to Natives or urban Indians, they are very solid upstream recommendations that account for minority health disparities. Specifically, the first recommendation, which recommends addressing social determinants of health, structural racism, provider biases, and other social inequities in priority populations, those risk factors that we just discussed. So this 2019 report found that 60% of the 100 total cases that were reviewed were preventable. Next slide. So it's been mentioned around during this webinar for a couple times, but you might be wondering how this information can be used to contribute to maternal mortality reduction in the US as a whole. So from this, the CDC has developed a tool to use for this purpose called the Maternal Mortality Review Information Application, or MMRIA, which is a data system and a data strategy designed to support the functions of MMRCs through common data. MMRIA functions as a standardized tool for data abstraction, case narrative development, documentation of committee decisions, and routine analysis of effective practices. As MMRCs continue to adopt MMRIA, the CDC Erase MM team will publish this data from the increasing number of combined MMRCs to provide the team with key national trends. In 2022, the CDC Erase MM team published a report on the review of pregnancy-related deaths among AIAN persons by MMRCs in 36 states from 2017 to 2019. And this information and analysis provided by this report is what gave us the information that Nala presented earlier in this webinar. So next slide. All right, well, MMRCs are considered the gold standard for maternal mortality review. As we all know, there's always, some barriers or challenges that need to be considered when implementing any sort of tool like an MMRC. So a 2021 environmental scan conducted by the Black Mamas Matter Alliance scanned 9 state MMRCs, and they reported on barriers of engaging with MMRCs. So this can include, this type of barriers for engagement can include, the lack of knowledge, transparency, diversity in the MMRC committee recruitment process. Also the lack of timely and consistent access to data and recommendations, and legislative hurdles that might impede community participation. However, these barriers can be met with strategies to promote MMRC participation and engagement. So all of these barriers and challenges are crucial to consider when considering AIAN representation on MMRCs. All right, so next slide. Oh, thank you. So now we will just open up the floor really quickly for any questions on MMRCs for myself and Alexandra. So if you have any questions, please feel free to type them in the chat or unmute yourself. We'd like to point out, Lucy mentioned in the chat that not all states require their MMRCs to be multidisciplinary, and very few require racial or ethnic diversity, i.e. Native representation on them. So this can seem like a catch-22 when things are left up to individual states. Yes, I agree. Yes, Justin, there is ways to encourage these committees to be more inclusive. And, there's a lot of factors that can go into that. Need a lot of like policy and advocacy, continuing to make those recommendations and follow through them, using, the logic model as kind of a guide. And then also, constructing policies to account for more standardized data collection to actually require reporting on, ethnicity for these death cases. Yes. If anyone else has anything else to shout out, please feel free. Okay, again, if you have any questions, please feel free to send me an email, reach out to our team, and we'd be happy to chat. Okay, so now I would like to move on, next slide, thank you, to introduce our guest speaker, Michaela, and she will tell us about the importance of UIO and AIAN representation on MMRCs and share her experience with us. So thank you, Michaela, for being here, and I'll let you take it away.
Awesome. All right. Hi again, everybody. So in preparing for today, I thought about having slides and decided not to have slides, but now I'm really regretting it because everyone had slides, and now, well, you have this picture of me, but now you're all staring at me. So I'll talk about my experience as a public health professional. So I have my master's in public health, and being a member on our state's MMRC, and then also just in my position at our Urban Indian Health program. So South Dakota Urban Indian Health. Unfortunately, I can't share like a lot of specifics about the data or cases we review in our MMRC, but I do still think what I can share will be helpful. And if you do have questions along the way, I think if you share them in the chat, I'll keep an eye on it. And if it's something I can answer as I go, I will, or I'll be able to follow up later if we have time, or I know Maddie will help me get those questions. But just wanted to throw that out there that you can ask them in the chat as I go. So honestly, I've really never thought a lot about a state MMRC before I joined South Dakota's. I've never been pregnant, so I don't spend a lot of time thinking about those experiences. I've always known that our Native relatives do face higher rates of maternal mortality. That's something we learn about it for anyone going through public health programming or education. Those are things you study, and those are things you pay attention to. I just never thought I'd be ever in this position that I'm in to talk about these things at such a high level at a state committee like this. When I was in middle school, before my mom had my little brother, who just turned 18 last month. So, but before she had him, she lost a pregnancy, and during that pregnancy loss, she also lost a lot of blood, and so had to be taken to a nearby town, nearby city for care, because we didn't have back on the resident system, we didn't have the hospital system to provide adequate care. I was young, so I don't know all the details, but I know that it was scary. My aunties and my dad were super worried, and I know she was gone for an amount of time, but like I don't know the details about everything. But like thinking back to it and all the stuff I'm learning about now, I think that I'm super lucky that she's not counted in one of those, like a number case that we're talking about for maternal mortality. But she could have been, right? If she didn't get the care she needed or the quick action. I've heard stories of how friends and family have had their worries ignored by their providers during pregnancy. So just throughout all of this work I've done, I think about how close I've been to losing any of them, and wonder if there are times I'll ever have to review a case of someone I know because of these inequities in our health system, or just the way our providers can sometimes not hear what's going on, or concerns for our Native relatives. So anyway, I got to be on South Dakota's MMRC for some reason. So last September, I got a call from someone at the state here in South Dakota asking if I'd be interested in serving on the state's MMRC. I was at a conference at the time, so I stepped out and just took a call with her. And the first thing I did was put my call on speakerphone and Google what is an MMRC. So I knew what I was talking about when I would turn her down, because that's what my first reaction was, honestly. I was going to say no, because I had enough experiences trying to make impacts and work with the state on other things, and I just truly didn't want to be another check a box for a committee so they could say they've worked with a Native organization. I knew I didn't have any time already, but I really respected and still respect the person who reached out to me, so I didn't say no right away. So instead I started asking questions, you know, what Native representation is on the committee already? What kind of engagement do you have? She shared there was little to no engagement. And we know there's so many reasons for tribal engagement on state committees, so I won't get into that. But so my next question was, you know, are you sure you want it to be me? Should I ask somebody who's a provider or somebody who like does direct care with our relatives? Because that's not me. I can't provide that for you. But what they came to was they were looking for someone with public health experience, because all of the rest of the committee, though they were physicians, they were the ones providing the care, but they really were interested in our urban program and how we provide care and the cultural components that we provide in our behavioral health and just that public health integrated care. So that's why they asked me. And so I obviously said yes, because here I am talking about it. I truly, like, the whole call while she was asking me, though, I was saying no in my head, like over and over and over, because I think many of us have had those experiences of being the checking the box and just knowing sometimes it doesn't amount to anything. But I thought about all of our relatives who'd they be talking about at these meetings. I felt just sad thinking about the stories being told, how they'd be scrutinized and judged, and what if the committee doesn't ask the questions or think about the things that I think about. You know, when thinking about our relatives, I knew eventually, like by the end of the call, I knew I couldn't not be there to honor their lives and their stories. So I said yes. I don't regret it at all now, being 6 months in. I think we've reviewed about 20 cases so far since I've been on the committee. A good chunk of them have been Native, so that's what I expected, but it's still been hard to look at those. So I realized honestly how important it is for urban programs to be on these committees, though, because so at least in South Dakota, many of our Native relatives come to our urban areas like Sioux Falls to deliver their babies, or babies come here for care in NICUs, or they just end up coming here for some reason and they stay here. And we know our urban Native population is continuing to grow. So I think that I didn't realize that until being on the committee and just talking about all the things and hearing about all the experiences that our Native relatives are having in the urban setting. So I think now it should be like a requirement for all MMRCs to ask urban programs to have somebody on their MMRC. So our clinic in Sioux Falls and Pierre, we have a huge focus on our cultural health. We have a cultural health department. And so I'm able to ask to see if culturally appropriate care or support was offered or provided to, you know, all the cases we review, and if they're Native, those are questions I ask. You know, most of the time we don't know that information, but it leads to good discussion and recommendations, and the OBGYNs on the committee can ask me, well, do you provide that care? If I have a Native patient, can I reach out to you at Urban, and can you connect me with, you know, a NEPI or Sweat Lodge or these programs? And, you know, so that has led to some really fruitful conversations, but those are questions I ask at every meeting and every case we review. You know, can we create a program for Native community health workers or community health representatives to get immediately connected with all Native folks after they deliver, and just be that connection? How can we provide the best, most culturally appropriate care for our Native relatives during and after pregnancy? So those are the like things we're all talking about at these meetings, which has been so impressive. So, you know, usually after the committee meets, we do have more questions than answers to all the stories. it's really shown me, and I knew this, but it's shown me how disjointed care is for our Native relatives, just how little support they're given in most healthcare settings. And even after they're gone, you know, their deaths are miscategorized, or one case we even had an autopsy was just dripping with racism and discrimination. You could read it in the autopsy. So there's just so many injustices happening from beginning to end, and even after someone's no longer with us. So it's going to take a lot more than one committee to rebuild this system. That just wasn't built for us and for our Native folks going through different cares. But I think that this is one of the most important things I've been doing lately, because we have really important OBGYNs on the committee, and most likely most MMRCs do. My gynecologist is on this committee, so I switched gynecologist because that's a little weird. But so they're like really prominent, you know, OBGYNs and state epidemiologists and all these people on these committees talking about these things. So it's great networking and abilities to help make correct recommendations based on all the case reviews. So I think that if nothing else, it's important for UIOs to be there and Native folks to be there to start making those connections, and then it could lead to something cool, and maybe more recommendations. I'm going to try to skip ahead a little bit more about the barriers. So I do want to touch on the barriers about being on MMRCs from my experience. So it's hard. And that could be a reason that it's hard sometimes I mean, there's a lot of reasons, but sometimes I think for Native folks, it can be hard to be in those spaces where we're talking so nonchalantly about death and suicide, and you hear all the details. And I think that I didn't know that going into it. Like you hear everything and you'll read everything, and it's hard to take in. And so I sometimes just have my sage burning the whole time I'm reviewing cases because it's that intense, and you hear all of those things. So it's hard. You know, I've cried during all of the reviews because it just continues to remind me how hard it is for our Native relatives to be cared for in a good way. Our society has truly given up on so many of our community members. So it's hard. That's a barrier. I think it's a reason that it just leads to non-engagement on these committees. Another really, really big thing that I'm hoping there's a way we can fix this, and it's more about barrier to doing effective work on these committees, is that in South Dakota, at least, we can't see the full story yet of everyone we're reviewing because we don't have access to historical charts and data for our relatives who've received care at IHS. So sometimes we'll have access to whatever charts and records from IHS that were maybe sent to the urban hospital or not urban Indian Health, but to like another private hospital that they're seeing. So that's a huge barrier for us. We can't see the historical background of what they've been through, all the puzzle pieces. It's just a big goal. So how do we get there? So I know that those are big hurdles, and it's a lot of privacy and confidentiality and things that we'll have to work through. But without the information, it's really hard to make the puzzle work so that we can create meaningful recommendations and develop effective interventions. It just in general, not having complete health records kind of makes you feel frustrated and like you can't get to the bottom of this mystery, because you can make all these assumptions and you could be wrong because you don't have the full picture. So just knowing that going into it, I think will be helpful if you're going to be involved or maybe asked to be involved, that there's frustrations along the way, and it could be nothing you could fix, and it's just something you have to try to work around. Another barrier is capacity. I think so many of us are stretched in over capacity already. It might be easy to dismiss a request like this, like I almost did. And it's also just hard to make that connection. You can't say no or you can't say yes if you're not asked. And so how are our state officials or people on this committee, how are they recruiting our members? How are they not? Like, who are they going to? How are they getting these people compensated? Like, thankfully, this is part of work for me, so I can do it while I'm at work. But what about community members who can't? So how can we really expand that? And Maddie, you touched on that a little bit too, but how can we cast a wider net there? I'm almost done here. I want to also share some of the themes that have come out of these reviews, and I think it touches on a lot of the comments and stuff that we've already heard from so many of you all throughout the discussions, but we're not doing enough to ensure follow-up care, I think, for our relatives, you know, before and after delivery. There's just not enough attention given to that peer-to-peer support or case management. I think there should just always be a way to connect our relatives to support sooner by a warm handoff and just emphasis being placed on that cultural support. And how do you find out if there's a way to, sorry about that, if there's an NEPI going on in that community, if your Native patient is not at home or they don't know the resources in your community, how can you find that out? Are you connected with organizations in those communities where you can help make those recommendations? Or as a Native organization or community member, can you reach out to those health systems and start making those connections to offer that support? But how do we get there so it's just part of a routine screening question or recommendation, or how do we get there? I think that is something I want to explore now. What I'm also seeing in the case review, and it's more in the looking at past charts and how things are documented, is but someone is always asking, you know, what's wrong with you, or why aren't you doing this or that, but we're not really getting to the root cause of why an appointment was missed, or, you know, what happened to you to lead to this decision. And it's a lot of blame and shaming, and no wonder people aren't coming back to appointments or following up with care or making some decisions that can lead to a poor outcome. I wish that we could put some more effort on making casual relationships and connections outside of the clinic. So for urban, I want to explore some ideas to make connections with our health systems that are seeing our Native patients through delivery and before delivery, and see how we can make that connection. And just to end on a positive note, because we've talked a lot about some hard things, but the experience I've had thus far with the committee members has been phenomenal. They're so receptive to my questions and my feedback. And when I push back and mention, you know, discrimination, or mention that I think something that just wasn't right, or it was discrimination or racism, they hear it and they talk through it, and they're not dismissive. And sometimes they're actually quicker to try to make changes than I am. So it's been really positive. And so I think I want to end on that, is that I can really see some cool things happening out of my experience on the MMRC in South Dakota. And so I think that if we had more urban programs on MMRCs, that'd be awesome, and just more Native representation overall. So I will stop there, and yes, I'll stop there, Maddie.
Thank you so much, Michaela. I was taking notes. That was incredibly insightful, and I will speak on behalf of our audience and say that that was incredibly robust and full of knowledge, and thank you for sharing with us. Your perspective is invaluable, and I'm sure all of the UIOs will find your knowledge is crucial as these efforts continue to increase to be involved in MMRCs. So next slide. Okay, so to close out, we'll open up the floor with a kind of closeout discussion to discuss some of the barriers and benefits that might exist for UIO participation on these MMRCs. So we'll spend a couple minutes here. So if you want to take some time to think about your response, please feel free to unmute yourself, raise your hand, type your response in the chat. We'd love to hear your thoughts. Or if anyone has any questions for Michaela, please feel free to ask too. Yes, the category of other. Absolutely. Representation. Justin wrote in the chat, representation is a huge benefit. In Kansas and Missouri, AIANs are currently othered in the state board. So if UIOs are represented, they will have trouble doing that, which is a great point. Yes, go ahead, Rebecca. Thank you.
I was just thinking that a barrier that comes to mind, not just with urban Indian organizations, but I think just Native communities in general, is that we don't emphasize experience as expertise enough. And I think that there's a lot of knowledge and wisdom that comes from somebody that has that lived experience, and we don't yet really put that at an equal level with, you know, the medical professionals and the degreed people. And I just feel like we would gather so much more meaningful solutions when we include the people that are most impacted. And so I feel like that needs to be emphasized more, and think that that would almost even change the perception of the community being involved, not necessarily them needing to be an expertise in the field, but that they can also bring their community knowledge with them as an expertise.
Thank you, Rebecca. I totally agree, and that really does build off of the emphasis that Michaela put on, you know, providing these supports and programs for community healthcare providers, because they are so crucial for you know, our relatives and our families. Great. Any other questions, comments, last closing words before we begin to wrap up? Okay. I will take that as a no. Again, if you have any questions, please feel free to email me. So next slide. Alrighty, so again, Michaela has graciously offered to provide us with some closing words to end this session in a good way, after all of the heavy information that we just covered. And if you can stick around after Michaela's closing words, we'll close out with some important information about our next steps. So Michaela, the floor is yours.
Yeah. Yeah, so we had a lot of information today, and I'll just kind of stress the same things I did at the beginning. Is after every discussion I have like this, I do like to take a moment and smudge, and I'll share what I do after the MMRC meetings. Even during, I'll take a break and just think about the folks we've talked about, and you know, their circumstances that they've been through, and just, you know, like the things they went through were not in vain, and all the things we've talked about today and all the things our relatives have gone through, it wasn't done in vain, because we're talking about it and we're doing our best to fix it. And so that's what I usually will focus on at the end of our MMRCs, because it's hard. And thank you, Rebecca, for sharing about the secondary trauma in the chat, because it's hard, and that's, I hope that everyone is taking care of themselves too. If you do any kind of work like this with our relatives, it's a burden. And if you're like me, you overextend yourself all the time trying to do everything. But I'll just close in saying thank you to everyone for sharing all the great insight and just sharing the space and having this important discussion. And if you know, at the end of this, I would encourage everyone to just take a minute to think about all of this and just to reflect so that you're able to carry on with your day and in a good way. So Pidamia, everyone.
Thank you so much, Michaela. Yes, I agree. Please take some time. So for some closing steps, to continue with this work, NCUE will be conducting a survey questionnaire to obtain an understanding of UIO level of interest of being involved in their MMRCs. So please keep an eye out from our team about this opportunity. You also potentially be provided with a stipend. We are also developing an opportunity for 2 UIOs to partner with NCUE for a deeper dive into UIO involvement on MMRCs. This opportunity will allow the 2 selected UIOs to travel to at least 2 meetings focused on maternal mortality, with the first being the CDC annual Maria user meeting in Atlanta this coming April. So please, again, keep an eye out from our team about this opportunity. And next slide. We'd also like to remind you all again to please complete the survey to provide feedback on today's event. You can scan the QR code on the screen or visit the link in the chat to provide feedback. And you also can enter to run a raffle to win a prize if you complete the survey. So we want to remind you again to apply for the partnership opportunity when you see it. And then also contact our team if you have any questions, and keep an eye out from us again about the questionnaire and any additional opportunities. Here's our upcoming events. Please note that NCUE's annual conference will be held from May 15th to May 18th, 2023. So make sure that's on your calendar.